lovely to see all of you, and thank you for coming out to episode 2 in our limited series on living with dying. I'm really delighted to tell you about the special guests and presenters we have this evening. In just a moment. It's really a seasonal transition when it's cooler inside than outside today. Perhaps we'll just begin with the prayer that we will open each of our evenings together in this Living with Dying series. I forgot to mention last week when I said this prayer that you'll note in it reference to the 23rd Psalm, which for many folks, in particular around times of death and dying, or in those moments, comes to mind for so many and is in the hearts of so many. So this is a lovely reference. Teach us, Lord, to be encouraged, to stand fast, and to boldly say with confidence, "The Lord is our helper, the Lord is our strength. Though we walk through the valley of the shadow of death, we will fear no evil. The Lord is our supplier of all things. The Lord will supply all that we need." Lord, help us to dismiss our fears, put our trust in you, and listen to your calm, comforting, and still voice. In your precious name we pray. Amen. So welcome again to all of you to this second gathering in this 5-part series on living with dying. This evening we will be treated to much wisdom and expertise and information regarding palliative care in its various aspects and dimensions. And I'm so pleased to introduce to you 3 official guests and 1 bonus guest who has come along this evening. And we're really blessed by their presence. So first, I'd like to welcome Naomi Mitchell, who has more than 14 years experience working as an occupational therapist in the extramural program, and in the last few years, she's been working with the Extramural and Ambulance New Brunswick Palliative Clinical Practice Leadership Committee, and more recently with the Palliative Care Work Group in the province. And so Naomi has a real heart for palliative care and works as an extramural OT. So she's extra special to me because I happen to be married to an extramural OT. So really grateful to Naomi for coming and sharing with us tonight. And Naomi will be kicking off the remarks once we get started. The second to present is Ryan Brennan. Welcome, Ryan. Thank you for being here. Ryan is a family physician working in community practice here in Fredericton, and works occasionally in oncology and inpatient care at the DEC. He's in his training some years ago, he was involved with the palliative care specialty team during his training. And something I find very interesting, Ryan is also a member of the Greater Fredericton Baha'i community. So thank you, Ryan, for your presence and offerings this evening. Third to present this evening is Jennifer Gillis Doyle. Thanks, Jennifer, for being here. Jennifer has 16 years' experience as a palliative care physician, specifically. Was named a Fellow of the Royal College of Canada in 2019 with a subspecialty in palliative medicine. She does work in inpatient and community palliative care, as well as assisting with the coverage, the physician coverage at Hospice House here in Fredericton. And also happens to have been married in this very place a little over 20 years ago by Bishop Bill Hawken. So this is a special space for Jennifer. So thank you, Jennifer. And Jennifer brought along with her, or met here this evening, April Jewett. And April Jewett is did I overhear correctly, more than 35 years a palliative care nurse, and is currently a nurse educator in the realm of palliative care. And so April's come along with a great deal of expertise in this area as well as some tips and materials that she's found helpful. So I think Jennifer has plans to recruit April in her presentation. So we're just delighted and so grateful that you're able to be with us this evening and make a pretty crackerjack, illustrious panel. And I'm sure there will be lots of interest and questions. The format will plan to have be as close to what we did last week as possible, which we'll invite the presenters to come and share a few minutes of their insights into palliative care from here, and then we'll leave a little bit of time at the end for question and answer, and I'll roam around with a handheld mic so folks can give voice to their questions when we get to that segment. So pretty straightforward, and again, just really grateful and eager to hear what you all have to say. So without further ado, Naomi, it's all yours. Thank you.
Hello. Can you guys hear me okay? Yep, good. So like Kurt said, I've been with the extramural program for about a little more than 14 years. When I first started out as an OT with extramural, I was pretty terrified when I heard the word palliative, and had to go out to see my first palliative patient. I was quite intimidated by that, and that just kind of reflecting on that, getting ready for tonight, I think that fear came from the unknown and not knowing what it might look like, and just the weight of the word palliative. It kind of comes with a lot of assumptions and unknowns, a lot of questions. Now, I feel quite privileged to be a part of people's journey when I have that opportunity to be in their home and be a part of their palliative care. I learn something professionally and personally each time I meet someone, not just in palliative care, in every home I go into. But especially with palliative care, it's a pretty meaningful part of our practice. So I feel privileged to do that. I think it's great that you're doing this series because I'm thinking that I'm probably not the only person who's felt fearful by hearing the word palliative, especially if it's more on a personal level. So hopefully, not just in my presentation or ours tonight, but through the whole series, you'll get more information and have less maybe anxious feelings or concerns about death and dying in that conversation. So just an idea of extramural in general, for those of you who might not have had the chance to see us out in the community. A lot of people will call us the hospital without walls. We serve people who are homebound, who aren't able to get out, or it's very difficult for them to get out of their homes, or they have specific needs that need to be addressed at home. So that might mean it's related to their environment, or just for whatever reasons need to be seen in their own environment. Our team includes basically anyone who would see you in the hospital, all the different therapeutics. So I'm an occupational therapist, there's physio, social work, speech therapist, nursing, LPN. I'm forgetting people, and they will be insulted if they're watching. SLP, respiratory, all of them, dietitians. We all try to work as a team as best as we can, and I think that's one of our strengths, actually, to be able to provide all of those things in the home when needed. If you ever do have extramural involved, you may only have one or two of us, or you may have the whole team. So just know that it can be different even within the same person. If you had extramural for different reasons at different points in your life, it may look very different depending on what you need. And we really exist to, help people to stay at home, be safe at home, to manage their symptoms, and have a good quality of life in home and prevent hospitalization when it's not necessary. In terms of palliative care specifically, we get referrals often from the physicians. That's usually where it comes from. And I would encourage you, one of my main things I wanted to talk about tonight is just consider accepting the referrals as soon as they're brought up. The earlier that we're able to come in and meet you, the earlier in your process or journey of palliative care, the more we're able to support, what is important to you. I find sometimes we end up coming in later in the process, whether it's, we didn't know about the concerns until later on, or there was a hesitation to accept people coming into your home. And it's more difficult to have those more meaningful conversations about your values and your wishes when we're doing a bit of damage control, right? And if we're in crisis mode. So I would encourage you, if you ever do have that conversation with your physician or whoever it might be about a referral, to be open, as open as you can be. We do our very best to support people's wishes when it's coming to end of life. I think that's one of the more meaningful things, I shouldn't say more meaningful, but one of the meaningful things that we do at Extramural is if you have those kind of final wishes that you're hoping that you can experience in your last days, weeks, months, we do our very best to make that happen and to support you in that. So whether it's, a trip out to your camp or getting to a family member's wedding or something like that, we do our very best to help support that. So if you're ever in that situation, don't hesitate to ask, is there any way we can make this happen? And on the topic of values and what's meaningful to you, another thing that I really wanted to emphasize tonight too is talking to your family about what you want, whether it's those wishes like going to your camp or that type of thing, or what treatments do you want to have, and these guys can probably speak more to that than I can. But I did bring this handout that Kurt would have given you as you came in. It's a good guide to just start thinking about some of those questions, some of the things you might want to talk to your family about before you get to the point that you may not be able to have those discussions, so that the person, your substitute decision maker, we call them, whoever you've appointed to speak on your behalf, if that situation arose that you needed someone to speak for you, they know what you would want, right? And you know that they're going to speak from what you wish, right? Not from what they're wanting, but from what you want to have happen. I heard at a presentation a year or two ago about someone referred to the substitute decision maker as an understudy. So I thought that was a great kind of picture of how to think of whoever you are deciding to involve in your care and your planning. Think about involving them as soon as possible so they really do understand what you're going through, what you've been through, and what you would like to have happen in different situations. And then extramural in the home in a palliative care situation, I just wanted to give an idea what that might look like. I mentioned we have various professions on our team, so you'll see a number of us come in depending on what your needs are. We might bring in different pieces of equipment to help support your care at home and your safety. We have nurses who are 24-hour on call. So when you get into situations, that you don't want to go to the ER, it's not an emergency that you have to go for, but you really do need someone, we do have that service as well. And the frequency of how often we come to visit you, it all depends on where you're at, what your needs are, but also what you want. Sometimes people are feeling like there's so much going on when you're in a situation like this, such as you approach end of life. And it's okay to speak up if you ever are in a situation where it's overwhelming and say, there's too many people coming in, we need a little space for us. right? I always try to stress that with my clients. We work with your families, with your support system to support them as well and educate on, any care or help that they may need to provide to you or family member. We help to link with the physicians, with the hospital, with pharmacies, with social development, with insurance companies, equipment vendors. We can kind of help with that piece as well. So it can be pretty overwhelming when you have all of these factors that you have to be looking at, and sometimes we can help alleviate a bit of that by, saying, well, we'll take care of that, communication piece or arranging that piece of equipment. You don't need to call your insurance company. You've got enough to do, with appointments and that. We can help offload some of that as well. To keep in mind that we're able to often support, there's very few cases that we can't support someone dying at home if that's their wish. But palliative care doesn't have to mean staying home until the very end either. It can be supporting your palliative care until the point where you're feeling you need to go to hospital or hospice. So it can be either or, depending on what your wishes are and, what the capacity, what your environment is like, what your family is able to take on as well. We try to consider all those things. And bottom line, really, you direct your care. So you get to decide what matters most to you, and we will respect that. We're coming into your home. It's not our office that you're in. We want to respect, your traditions. We want to respect your beliefs, your comfort levels with, like I said, the number of people coming in and out, the equipment we might suggest, all those things. You guys get the final say, and I always like to stress that. That's about all I had to say. I will just say that attached to this Speak Up information here, it's kind of a starter. There's more information online, kind of a more comprehensive guide to questions that you can go through. There's another checklist attached to it that we sometimes hand out to patients. It's information that will be helpful for your family after someone passes. So it's information that they may need, for, tax purposes and those types of things, right? So it's very helpful, I think, if you can go through that and have that prepared. You don't have to give it to them right away if you don't want to share that information, but then it's ready for when they need it. And the last page I really like. It's called the Dying Person's Bill of Rights, and talks about a few of the things I just mentioned there. I just like how it's laid out about the different rights you have to basically direct your care and have your beliefs and wishes respected. So I think that's it. Thank you for having me.
Many years ago, I stood at the front of this cathedral, so it's a bit of and I actually forgot to wear my wedding ring tonight, so I feel a little embarrassed. It's actually all good. So it's my absolute privilege to be here this evening. Is that too loud and echoey? I do have a pretty loud, it's good. Okay, thanks. And I thank Ryan and Naomi for their words. There's a lot of overlap in the presentation I was planning to give. And I'm really excited that two of my compatriots at the hospital, both Lorinda and April, both very experienced palliative care unit nurses, are here this evening. So I am going to call them up to give a little presentation as well, or a little discussion. What I thought I'd do today is kind of talk about if you were in my office for your first visit, either as yourself, a patient, or with a family member. So I have a little spiel, like I'm a car salesman or something, that I go through and I kind of tell everybody kind of what palliative care in Fredericton looks like. And that way you have all of the information, and then we kind of from there would focus in on what symptoms that you've brought to the table today or your loved one has brought to the table, and we'd spend most of our time kind of talking about that. But I'd like to give everybody kind of a good overview of what palliative care looks like in this area of New Brunswick. In the question and answer session, if you have questions about other locations throughout New Brunswick, I'm happy to field those questions as well, but I'm really going to focus on Region 3, which is the area that I work in. So there are 5 full-time palliative care physicians now in Fredericton. When I originally moved back from Ontario, there was myself and one other, and we had one physician who helped out 8 hours a week. So our program has really grown over the last 10 years. It's fantastic. And with that growth, we've been able to expand the area that we cover. So now we cover all of Region 3, which means, and I had to get my husband to help me with the geographics, because I could kind of say I know where Macadam is, but I couldn't figure if that was like northwest, southwest. So I've got it all organized. So we cover northwest to Grand Falls, northeast to Doketown, east to Cambridge Narrows, and southwest to Macadam. And Region 3 is the largest health unit in the province. So our 5 palliative care physicians cover that area. We could never do that on our own. We absolutely are so dependent on primary care providers, both nurse practitioners and family physicians, and extramural, boots on the ground, people that we rely on to get the information for our patients. But that's kind of the geographic area that our group is responsible for. We have a shared care approach. We are all, the 5 of us, are specialists in palliative medicine, so we all look after patients together. So we share an electronic medical record. So if you were to come to my office, you might meet me or on our first visit, but the next time you come, you might be one of my colleagues. And that's fine, because that person is going to have the same access to the information. We all work out of the same office. Our office is located on Churchill Row. We're on the 4th floor of Hospice House. So many of you might be familiar with hospice. We used to be at the deck, but because our program's grown, we decided to move down to Hospice House and have our office space in that facility, which has been lovely. And that gives, that kind of shared care approach means that there's someone available 24/7. So 24 hours a day, 7 days a week. We all put the same information into the medical record. So if we happen to get a call on a weekend, maybe I've not met you before, but I still am able to see what the last conversation was about, which is really helpful because patients and their families get sick of telling the same story over and over and over again. I'm seeing lots of nods. Yeah, it can be exhausting. So we may need some specific details and get a little bit more up to date, but in general, we should have your records kind of all together. We see patients in 3 different settings, so I think that's important to kind of tell you a little bit about. I mentioned we'll see patients in our office. Those first palliative care consults are usually about an hour because we do a number of questions. We do some research, so we try and kind of establish a baseline of what your symptoms are like at your first visit, and then we'll track those numbers over time to give us a sense of how successful we are. There's some good evidence across Canada for these special scales that we use. We also see patients as home visits. So if a patient isn't well enough to come into the office, we'll certainly go and see them at home. Obviously, in those rural and remote areas that we cover, up Doketown Way, Grand Falls, it's really challenging. Like, it could take a full day of travel just to see one patient. If we needed to do that, we have the staff to do that. But now with virtual options, we really try and take advantage of either Zoom or telephone or, try and kind of maximize that or meet with the nurse. The nurse might be out, an extramural nurse or other extramural person might be at the bedside, and they might call us from the bedside, and we kind of had a conversation, or we might do it on Zoom in that way. So that's been really one of the good developments in the last couple of years that's really allowed to provide more comprehensive support in those kind of rural and remote areas. Whenever I kind of say this about rural and remote, my colleagues down in St. John say, yeah, well, we cover Graham and Ann. So there. So there's we all kind of compete about how far we have to go, but there's days where we can spend a lot of miles on the road. We do offer outpatient outreach clinics. So every month, one of us will go up to the Upper River Valley Hospital and see patients in that area and do home visits kind of up that area, Heartland, up towards Grand Falls, it's that kind of area. Then we also see patients in Macadam and Harvey, and we have a Minto Chipman clinic as well. So we'll go out to the healthcare center there, see patients, and also do some home visits while we're out that way. So The other third location is as inpatients at the hospital. So if a patient has been seen in the community and they happen to be admitted to the hospital, so we've seen them in the community, we've accepted them to our program, and we're following them, and they get admitted for some reason. Usually we'll get alerted through the computer system that they've been admitted, and we'll try and drop in and see how things are going, and is there anything that we can help offer and support. It's not a perfect system, though, I'll say, so it's always, if you are in that situation or your family member is, it's never a bad idea to call the office and let us know that somebody's in there, because I don't know enough about computers to tell you where the problem happens, but I know that it does happen sometimes, and we don't always find out right away that someone's gone into hospital. The other thing is we may meet you for the first time in the hospital. So one of our palliative care physicians is in the hospital kind of on a weekly basis. So we go Wednesday to Wednesday, so goes into the hospital, looks after our inpatient palliative care unit, which is 8 beds on 3 East, and then does consults throughout the hospital, getting to know referrals and patients that other attending physicians would send our way. People usually to kind of meet, maybe provide some advice around complex symptoms. And then that person works through the weekend. Then the other physicians are in the community kind of doing home visits or covering extramural call or kind of supporting them in that way. So as I said, if you met someone in the hospital, you may meet someone different in the community, but again, it's okay because of that shared care approach that we have. So our palliative care unit has changed a great deal in kind of the time that I've been back here in New Brunswick. So it's really transitioned with those 8 beds to an active, aggressive symptom management unit. So the focus of palliative, and that's consistent with across the country palliative care units. So the role of the palliative care unit used to be very much an end-of-life care unit. And there are definitely patients that die on our palliative care unit. That is certainly something that we do, an important part of what we do. But we also do a lot of discharges. We send a lot of people home. And we also do a lot of direct admits, which means if you were at home, you're really struggling with symptoms, I can't get on top of it, but if I can just bring you into hospital for 4 or 5 days, I'm going to start you on a pain pump, I'm going to do some interventions, I'm going to get you seen by a specialist, and then you're going to go home again. So those short, kind of aggressive, manage your symptoms very quickly and home again are one of the big things that I think our program's really advanced in the last couple of years. And it's a big win. A big partner in that win is hospice. So patients that would have, prior to Hospice House, which I understand you're having a presentation on next week, so I won't steal their thunder, but prior to Hospice House, many of our patients wouldn't have had a place if they couldn't go home for end-of-life care. They would stay on our palliative care unit. Now, many of those patients will transition to Hospice House for those last months or weeks or days of life. And our unit has that flexibility to kind of be more aggressive in terms of symptom management and kind of meet the needs of those complex patients that need kind of expert advice around their symptoms. And when I say symptoms, I hope everyone, I'm talking about pain, severe nausea, restlessness, shortness of breath, kind of anything that might come from a variety of different illnesses. That's a common question patients ask me is like, who do you see? So our group sees about 80% of our patients have a cancer diagnosis, and about 20% have some other serious illness. And our only qualification to be involved in our program is a life-limiting illness. So, as I said, most often a cancer diagnosis, but it might be heart disease, end-stage kidney disease, it could be ALS, various neurological issues, anything that's getting very challenging to manage. One of our colleagues, family physicians or nurse practitioners in the community, would send a referral, ask us to be involved, and then our level of involvement will depend on how complex that patient is. They'll still stay with their family physician, the vast majority, and we'll kind of provide support and advice to that physician or nurse practitioner and to the patient. We'll dictate a note, that note goes to the specialist, it also goes to the family physician so that there's good continuity, but we don't necessarily need to be the most involved person because there's only 5 of us and we're covering that big area. But there is a certain subset of really complex patients, often very young patients, or with really aggressive disease or very, very difficult to control pain, those people are going to continue to have their family physician, but we're going to be the people most involved. So those are the ones that I might be seeing on a weekly basis, touching base with them 2 or 3 times a week, just making sure as we're changing medications or doing adjustments. So it really depends. Our group, we try and be very flexible and kind of roll with what's going on in that individual's life. As Naomi mentioned, we're very much focused on what the patient's priority is and what the family's priority is, but these are kind of some of the ways we can't be involved with every patient who has a serious diagnosis, because most of the time their symptoms can be really well managed in the community by their primary care provider. If that person needs advice, they can absolutely call us 24/7 and we can say, oh, have you tried this? What about if you rotated them to that? What about this? And we'll kind of talk things through, but we don't necessarily need to see every single person. Some people there's a lot of anxiety, and Naomi mentioned this about coming in for a palliative care referral, and it's surprising to me the number of times we offer a referral and patients decline it, or they don't show up to those referrals, those first consults. And I think that just comes from a place of fear. It's a scary word if you don't understand what palliative care means. Palliative care, like I tell patients this when they come see me, I looked after patients for 9 years, 10 years. It's not simply end-of-life care. It's patients whose needs are complex, and they need a team of physicians and nurse practitioners and nurses and everybody involved to make sure they have the best comfort that's possible. Hi, how are you, Debbie? So we do a lot of laughing in the office, too. People often kind of wonder, it must be a pretty dark place to work. How do you do that every day? And how do you keep going back? First of all, it's a privilege. It really is. You get to know patients and their families on this whole different level. I often relate it to times of birth. Everyone has a story about birth. So they talk about it was a snowstorm and your mother had to go through the storm to get to the ambulance. Everybody kind of has that. And the same thing with death. Those moments at end of life are often a story. I can tell you the story of my grandmother's death and how that looked. So to be kind of involved in those intimate moments and be able to be supportive and hopeful and helpful is really a joy, and that's what keeps us doing the work every day. And we also we really focus on hope. I think if you were to come to our office, you'd be surprised we don't have, the Grim Reaper hood, and we don't have the big sickle, and we're really pretty easygoing. Our admin are hilarious. They're really friendly and nice, because we want you to be comfortable and we want you to come back. And we want to make this the best quality experience for you and your family as we can. So as Kurt mentioned, one of our other responsibilities as palliative care physicians is being involved with Hospice House, which that's just amazing. If you have had the chance or opportunity to visit or be involved in any way, it really is. We are very lucky in this city to have hospice. Our role as palliative care physicians are to triage who's the next most appropriate patient to go. So most patients, I'd say 90% of patients that go to Hospice House have seen myself or one of my colleagues. And that's usually kind of to make sure that they meet the criteria, that everybody understands, and that their needs can be appropriately met at Hospice House. Because it's such a wonderful spot, we have a lot of people that would like their family member or loved one to go there, but they aren't always appropriate for the services that are available at hospice. So I call myself a little bit of a gatekeeper, which is usually a really good experience, but it can be challenging too. I hate disappointing people when their family member is not appropriate for hospice, but if some patients went there when perhaps they should be at a nursing home, we wouldn't have the flexibility of being able to admit people in an urgent manner, which we can. They'll talk about this next week when you have a presentation from hospice, but we're lucky. I mean, we can access a bed for hospice in 24, 48 hours normally. Sometimes it'll take a couple of days, but it's very rare for it to be more than that, which is because we keep the most appropriate patients there. Wanted to talk about our work with Extramural. So there is no way that we could do the job that our group does without the communication with extramural. Our group is available to the extramural service 24/7. So if a patient is seen by our program, they're admitted to extramural, that extramural nurse or RT or OT can reach out to a palliative care physician on call 24 hours a day, 7 days a week. And we meet with them every month. We talk about mutual patients, and we do that with not only Fredericton, but Oromocto, Minto Chipman, Grand Falls, all the way up in that whole Macadam, that whole area, just so that we have the best, most up-to-date information on what's actually going on in the home. So the work they do is just incredible. Again, we're very lucky in this province to have that. Where I am concerned about this province is the state of primary care in this province. I'm really concerned about what's happened in the last 6 months. We've lost so many family physicians. In Fredericton area and Upper River Valley have 6 family physicians retiring in the next 2 months. There's no one to replace them. And if those patients have no one to go and provide their primary care, their needs are not disappearing. They're still going to need the same level of care. And as a specialist, I can't provide that role for them. We can't. If the 5 of us try and replace 6 family physicians, there's no way we wouldn't be able to see all the other patients and do the home visits and all of that stuff. So we are at a really crisis situation in this province when it comes to primary care. And I really am worried about how that's going to play out. Yeah. So thank you for the opportunity to give you my little spiel on palliative care. I hope you have questions. I would like to take this time and opportunity to bring up April and Lorinda if you want. As I mentioned, both of these are very experienced palliative care unit nurses and would be happy to kind of talk to you about their view on palliative care because they're both passionate about it as well. So thanks.
Thanks for having us. I'm April Jewett, and I have been on palliative care for 36 years. So it started in '88 with Dr. Grant. We opened the unit in '88, and in the last year I moved on to do medicine education for the family med units, but my heart is with palliative care, so I still get to go back there and help the new staff along and help with education, so that's a good thing. I said to Lorinda when we come, I said, let's tell some good stories of things that we have experienced and we have seen, because often at the bedside, we are with the patients a lot in the daytime, and they have fears and they have questions, and we often are the ones that help to relay those fears a little bit or bring those questions to somebody who can answer them a little better than we can if they have other issues. But I thought we would share some of the stories because we both have different patients that have really stuck out to us over the years. And then I'll finish with sharing some resources that I brought with me that have helped me. And I've done a course with my church community a few years ago. Mm-hmm.
Sorry,
Yep.
I have a friend here who needs a little bit of medical help. Thank you. Sorry.
That's okay.
Low.
So I'll start with when I first began with palliative care, and I was afraid because I didn't know what to say. I didn't know how to go to those deep conversations with patients, and I had to just slowly develop that and be comfortable and be okay with silence, because I think a lot of times we like to talk a lot as opposed to listen, and we need to be able to listen and be attentive instead of drifting off and looking out the window and what time is it. And so being attentive is very helpful. My patients have been some of my best teachers. I had an ex-con for a patient many years ago. He had done some really hard time, and he wound up in palliative care and was on very high amounts of medication. I thought, wow, and he's still walking and talking, and he just reflected on his life, and he said, don't wait to do the things that you want to do. Take the time. Do the things. Go on the trips. Don't wait till you retire. You may never get there. We have no guarantees. Do those things. And the other thing he said is try and repair your relationships, because I didn't, and I have regrets about that. So I thought, that's very good advice. So I always try to focus on what I'm going to learn, because they're very good teachers, our patients, right to the very end. There's always a purpose for why they're there. Some people think, well, why am I still here? And every day there's a purpose. And so one gentleman that I had, he had a really dry wit. And I said, I think today your purpose is to tell me a good joke so I can have a good laugh. And so every day I went in to see him and I had a really good joke he would tell me over and over, something different every day. So that was a bright spot in my day, right? I kept looking forward to going to see him and trying to help him out. And I think the goal for me is trying to keep patients comfortable, trying to meet their needs as best I can, listening, being present, answering families' questions, because it's a hard thing to go through. It's okay to cry. Some people have a hard time with that, not wanting to cry in front of their families, but you care. And so tears are going to come. When you love deeply, you care deeply, and you share that grief. So, yeah. We've had great things happen on our unit since I've worked there. We've had 2 weddings. So we've had people that have lived together for several years or been in a relationship for several years, and that has become an important thing for them at the last. So 2 different weddings at different times, and we had a lovely garden years ago out there on the palliative care deck, and it was absolutely stunning. The bride in the first scenario was too weak to stand, but her dad very proudly helped her to stand from her wheelchair and held her so she could say her vows. And her sisters bought the most lovely white satin pajamas, and the nursing staff dressed her all in her white pajamas, and other nursing staff decorated the room all special. They got an extra bed pulled in beside her bed, and then there was a sign that went on the door, honeymoon in progress, that night. So we didn't interrupt too much, but we have good things that happen. We have people that bring in their pets, and like those are special things. So yeah, we have lots of fond memories of patients. We had a gentleman with ALS not too long ago, and I remember it became my desire every day when I went in to make him smile, to share a funny story, or to let him tell me a story. I said to him, "You are so wise. You're one of the wisest men I know," because he was always watching like Discovery Channel or something that was like developing his knowledge. Anyway, he was just a wealth of joy, and I could tease him, and he wasn't able to speak at this point, but he had a little board that he would type on, and he would always have a smart comment, and I would get that little grin, and so yeah, it was good. Good memories of the patients. Keep you going. Yeah. Do you have anything you want to share?
I agree with April with pretty much everything. So I started in palliative in 2007. I had done my preceptorship there, and then I came back after. Can't hear me. Sorry, I'm not a super loud talker. Anyway, I started working in January of 2007 in palliative care on 3 East. Absolutely loved it. And I ended up following April into education last year as well. So still loving that as well. I do miss my palliative patients, though. I really enjoyed the connection. You do learn something from each person that you meet. You get to share the joys of vow renewal. That was one that a patient really wanted to do. He surprised his wife, and they did a vow renewal. I don't think there was a dry eye on the floor. It was very emotional. We get to celebrate grandchildren that are born to some of our patients. And we love seeing the pictures and meeting the babies, meeting the families. Everybody almost becomes like a family member in a way. I have lots of memories of people, and they're all pretty good. I won't lie, like, we do cry. We do have those emotions as well. We do miss our patients when they go, but we're also happy that they're no longer suffering. But we're thankful to be a part of their journey. And as April said, I think most of us feel like we try not to take our life for granted, the ones that work there, and just appreciate every day that we have as well. Yeah. I find we tell stories to some of our patients as well. So I have a daughter, Zoe, who's 11, and many of my patients would ask, how's Zoe today? So, because we just talk about our children, our grandchildren. So yeah, it can be a really beautiful experience as well.
So on a personal note, I've been through the use of extramural with my uncle at home. The beds on palliative were full the weekend that they needed them. Emerged, the stretchers were lined up in the hallway, as we know can happen, and they called me and said, what do we do? And I thought, oh my goodness, this is not the place for him. We didn't have hospice then. That was prior to hospice. And I said, call extramural, I'm coming. So I packed a bag and away I went. And I stayed with him at home, so that was a little bit different experience for me, but extramural was fabulous, absolutely fabulous. I thought of all the things that I might need, not knowing what would happen at home, and they were able to get everything located and situated, and it was wonderful. And when he passed away, the room was full of family. Funny story, really. When he passed away, I started humming Amazing Grace, just humming. Nobody knew where it was coming from. And some of the gentlemen, they were looking at one another. What? You singing? So I met one of those gentlemen yesterday, and he recognized me by name, and I had no idea who he was, but he told me who I was. I went, oh, right. Anyway, so yeah, and sometimes it's difficult when you go through things as a family member. And so as a staff member, it can be difficult too, but as a family member, it's a different level. Again, because you are on the side of being a family member as opposed to a staff. So you have to have strategies in place for how best to cope. So I have a few books here. One that I found particularly good is Tim Keller. It's called Walking with God Through Pain and Suffering. Really good book. The other one that I have is Final Gifts, and it's Understanding the Special Awareness, Needs, and Communications of the Dying. So it is very helpful when you're talking with somebody who is dying. There's some real gems in that. For how do I talk to them? What kind of things are they really needing? Maybe they're not saying. And the other one that I brought with me was a reference to the course we did on death and dying in my church several years ago. We had a funeral director come as part of it, but chapter by chapter, it kind of guides you through how to make your going away file, it calls it, where all your numbers for your bank accounts and your insurance files and all the gifts that you would give to your family, right? That would be so helpful to know where everything was. So that book is called You Only Die Once, Preparing for the End of Life with Grace and Gusto. So it's a good book. It's funny in parts, but it does guide you through a lot of things. That one's by Margie Jenkins. So I think we're pretty much done. If you have any questions for us all.
Thanks, April and Lorinda. And how about a round of applause for a wonderful panelists this evening? such a gift and a blessing to have so many lenses on all that is palliative care. You know, from the primary care physicians through extramural and the nurses and physicians all involved. So I'm really grateful to all of our guests this evening for what you've brought.